Welcome everybody to the SHIP 2026-27 webinar. We're going to go through a lot of things quite quickly. We've got some great options coming up for 26-27. But first, let's go through all the admin. So I'm going to lay out a lot of information. You will receive the slides. This webinar is being recorded. So yeah, let's move on to what's going to happen today. We've got our upcoming deadlines and requirements. I'll talk a little bit about the types of investments. And then we've got three presenters, one from the Hospital Association Information Center, one from the Co-op, and one from Stratis Health, each telling you about project options. And then we'll have a quick Q&A, and then feel free to email me with questions. We'll have a little bit of time for question and answer. So if you have a question, please put it in the chat or put it in the Q&A. We will be monitoring both of those, and we'll try to answer them as the presenters are presenting. So don't hesitate to put your questions in immediately. Okay, our SHIP 2025-26, that's the current year. We're now in the SHIP 25-26 year. We've got three things that are ongoing. The first is, please, there are still 14 SHIP contracts that are not signed as of today. Please make sure your SHIP contracts are signed, because then you can start invoicing. The second thing is, if you have a signed contract, feel free to send us an invoice already. You can do it all in one go, or you can do it in batches. We have the invoice template, and you can send that directly to RSP. You don't have to send it to me or to Megan. And that there's a caveat for that. Those are only if you are invoicing us for HCAP's vendor fees. If you're not, I'm not sure what you're doing, because that was the allowable investment for this year. If that's something that you don't want to do, please send me an email. There are other options. I just have to pre-approve them. I can't just pay an invoice without having pre-approved it. So please send me an email if that's not something that, if you're not spending your funds on HCAPs. And then the other thing is, I know that everybody has a lot of turnover in various different hospitals. If your facility's SHIP contact has changed, please email Megan. Now's a good reminder to do that. Just shoot Megan a quick email and she'll get our contact list updated. The next step for this SHIP year is our midpoint report. It is very straightforward. It's not a report where you have to write all about everything that you've done this year and invite people to the table. It's basically asking, have you started spending your funds yet? And are you going to keep spending? Like, do you expect to spend all of your funds? So that should take you about 5 minutes to do. And it's part of the application for next year. So that's just a reminder, when you do your application, go in with an understanding of the fact that you will be asked, have you started your project yet? Are you going to complete your funds, using your funds? And if not, why not? Pretty straightforward. Let me know if you have any questions about that. Then May 31st, that is the end of this fiscal year, and the last day to spend your funds. And then June 15th is the last day to invoice. So it's under ongoing, but there is a deadline for that. Then June 30th, we'll have a more in-depth report about things like lessons learned and how you spent your funds and what your experience was like of SHIP. Okay, the upcoming year, we have January 7th. You are here, attend the webinar, or later on watch the recording, which I think quite a few people will be doing. January 7th, that's today, until the 20th. Request pre-approval for alternative investments. I'll talk to you a little bit about that in a minute. January 23rd is your final day to apply for SHIP 26-27. So that's on the same application form as that final, as that midpoint report that I spoke about on this slide. Undetermined, that's my favorite word. what'll happen after January 23rd is I submit the state application for Wisconsin to our federal funders, and then they make the determination of the final amount that each hospital gets based on how many hospitals apply. And then they distribute notices of award to each of the states. That is undetermined. As soon as we get those awards, we can start working on contracts to get out from the Office of Rural Health to you. But until we get that notice of award, our hands are unfortunately tied. So that's how we got into a situation this year where our contracts started going out in September instead of in June. But yeah, hopefully we'll have a better run this time. Everything should be on schedule this year unless there's another government shutdown. But I'll keep you posted as soon as we get our notice of award, and then we'll start processing contracts as soon as we can. June 1st is your first day to start using funds. How are we using those funds this year? Glad you asked. So we still have the two different types of investments that you can do this year. The first is a network project, which means you won't have a contract with the UW. So there are already, I think, 16 hospitals who are in this boat this year, where you make an application and then we contract with the lovely people who are on this call today, and you get the services, but you don't have to do all the paperwork with us anyway. Those three last year were the Cavio Rural Health Dashboard. That's coming back up again this year. The Coordinated Quality and Coding, which is coming up again this year, but in a slightly different form. And the Stratis Health Social Drivers of Health Strategy, which is also coming up in a slightly different format this year. So this year we got our direct investments, which means you apply to us, we send out a contract to you, and then you invoice us against the value of that contract. This year, that allowable investment has been HCAPS. We based that on all of the previous 5 years of investments. What did people choose as their direct investment? That was to lower the error rate because we had to return a lot of invoices, and our federal program offices were questioning quite a lot of investments. So to make things more simple and straightforward and reduce all of the back and forth for hospitals, we narrowed that field to HCAPS. This year, we're opening that window just a little bit more. We strongly encourage HCAPS. If you do HCAPS, no further questions, great. Select HCAPS, excellent. If you would like to do something besides HCAPS, that needs to be pre-approved. So you need to send me an email, look at the allowable investments table that's linked in the slides, that you will receive the slides. Look at the allowable investments table, send me an email and say, I would like to do this project, and I believe it falls under this investment category. I understand that that's kind of challenging because you don't become a ship expert quickly. There's so many nuances in all of the allowable investments. So let's have a conversation about it. I'm happy to talk. But yeah, please make sure that if you don't want to do HCAPS, if you want to do something else, it must be pre-approved. And that deadline again is for January 20th. You must have sent me an email and received confirmation from me that your expense is pre-approved. Okay, so I don't want to take up too much of your time. Over to, who was first? Emily, to talk about the Cavio dashboard.
Thank you, Samantha. I'm going to go ahead and share my screen. If you're unable to see it, please let me know, but it should be hopefully appearing. Well, good afternoon, everyone. My name is Emily Holden, and I'm the Data Operations Specialist at the WHA Information Center. And today I'm going to be talking about and demoing some dashboards from the Rural Health Dashboard Project. First, just a quick little background on WHA and the WHA Information Center. WHAIC is a wholly owned subsidiary of WHA. WHA and the WHA Information Center have been partners with DHS for a while in the collection and sharing of discharge and claims data from Wisconsin hospitals and ambulatory surgical centers under Chapter 153 of Wisconsin statutes. Back in 2003, WHA worked closely with our governor to establish a contract between WHA and DHS, and the Information Center was born and has been under contract with the Department of Administration since then to lead the state's data collection efforts. The Information Center receives discharge data from every Wisconsin hospital and surgery center. The data collection is done on a quarterly basis in the amount of almost 3 million records per quarter. This is patient-level claims data and includes information such as patient demographics, diagnosis codes, procedure codes, place of service, just to name a few. In addition to this, the Information Center collects data via several annual surveys. From there, all of this data, both the claims data and the survey data, serve as a foundation for the creation of several publications, which are mandated by Chapter 153 and are ultimately made available to the public on our website. The Information Center utilizes this data to populate its data analytic and visualization tool called Cavio, transparency website such as Checkpoint, and other custom requests as received. Participation in the Rural Health Dashboard Project grants access to 8 curated rural health dashboards. The types of dashboards available include hospital summary, readmissions, top visit categories, and market share. Participants also receive data upgrades, support for the dashboards, and quarterly custom reports. So an example of how the data upgrades would work is if you're currently purchasing data at a fixed width data level, then you would gain access to the relational level data. Also, users who do not currently have access to Cavio, which is the WHAIC's data visualization tool, participation in the Rural Health Dashboard Project grants access to Cavio as well. I just wanted to share this slide. This is a list of all of the dashboards that are included within the project. So the bold-headed ones are kind of individual ones, but this first one you can see here, there's like a subset listed. So this Rural Health Dashboard is kind of the main dashboard. Then within, you have a couple different dashboards to select between different sheets. So I just wanted to explain why that one looks a little bit different than the other options listed here. Cavio, as I said, is another benefit participants receive for participating in the Rural Health Dashboard Project if you don't already have access to it. Cavio is a self-service analytics and visualization tool that enables users to attain deeper insights from the data. They're really powerful and interactive when used to gain those deeper insights. Cavio is currently powered by Tableau and is specifically designed for the Information Center's standard data sets. We know that some of the smaller hospitals may not have the same IT resources as the bigger hospitals and health systems, so this Rural Health Dashboard Project is a potential solution. These dashboards answer some of the most important questions from the data while saving you time to build charts from scratch, and then you as well get support with us when you use them. And so today there are a few dashboards that I would like to highlight and demo for you all. These are going to include market share, readmission, and then I'll do a brief highlight of Cavio and kind of what that looks like, capabilities within Cavio, that sort of thing. So the first screen you're going to see, this is kind of our Cavio main landing page. So this is when you log into Cavio, what is it that I'm going to see? So we have a couple different breakouts here on the top. We have a general analysis, which is where Cavio lives. So that's kind of the main general dashboard. We have quick reports that are available as well. We have a tab called specialized dashboards, which is where the Rural Health Dashboard slides kind of live. That's their place. And then over here, just some instructional videos on utilizing Cavio, utilizing kind of those Rural Health Dashboards, that sort of thing. So under specialized dashboards, so anything with the word rural in front of it is going to be a dashboard that you would have access to by participating in the Rural Health Dashboard Project. The first one I'm going to start with is rural readmissions. So I will caveat and say that I prepped most of these, but to open them, you would just go ahead and select one and it would bring you into a new window. But here I wanted to share what it looks like. So this is our rural readmissions dashboard. Um, Kind of just a quick overview of all of the dashboards. They're going to have kind of that consistent color scheme that's listing kind of your facility, whichever one is selected. That's going to be in a light blue. And then the peers that you select are going to be in a darker blue. So all of the dashboards have kind of a similar theme. When you come in, it's going to list the dashboard you're in and then the time frame that is included in that dashboard. So you'll notice for rural readmissions is going to be 4 quarters worth of data. And readmission data is always going to be 1 quarter behind our discharge data. So that's why you see 2025 quarter 1 listed here. The next thing you'll do kind of with all the dashboards, there's going to be some filters right at the top that will impact what is being displayed within the dashboards. So here, first thing you'll want to come in and do is select the facility that your facility.
Sorry, Emily.
Yes.
We can only see the white screen. Could you unshare your
Oh,
slideshow and reshare the dashboard, please?
yes. Sorry about that.
Thanks.
Let me try that one more time. How's that? Are you able to see it now?
Yes, thank you.
Okay, apologies about that. I'm sorry. You're probably like, what is she talking about? So sorry. Um, so this is okay. I'll just do a quick little recap. So the time frame and the name of the dashboard are at the top. You're going to have the different filtering capability options on the top. So here we have, the first option here is to select your facility, and then there is an option to select race and ethnicity if that is something that you're interested in kind of filtering down into. This first chart, I guess we're going to say here, is first number that we're looking at is going to be comparing a readmission rate from the current most recent quarter that's been posted. So for this one, it's 2025 quarter 1 in comparison to a previous quarter. So for example, this is going to be saying 2025 quarter 1 in comparison to 2024 quarter 4. So we're just comparing right to the one in front. Then the next timeline chart we have here is a comparison of your facility in comparison to your peers. So what you would do is you would come in and whoever your facility is, you can come in and select some specific hospitals that you want to compare your facility to. Maybe they're locally close to you, or that's just someone of interest that you want to compare yourself to. So when you would come into the dashboard, you're going to select the ones you want, hit apply, and then that will bring the rates to this graph. So like I said, once this gets loading, the hospital that's selected under your facility is what's going to be displayed in light blue. And then the darker lines are going to represent the peer facilities that you selected in this choose your peers. Now, while this is loading, I'm going to go and show you kind of the bottom. You're going to see a readmission rate by provider and a readmission rate by MSDRG. So these two, okay, so just going back, we can quickly see here, now the peers that we have selected, their readmission rates have been added, and we can see that displayed. But these two on the bottom, these two kind of interplay with each other. So the readmission rate by provider, I'm going to just quickly go over what this bar chart, what this is kind of looking at. So let's say for this MSDRG, the light gray are discharges with no readmissions, and the dark gray is a discharge that had a readmission. And then this dark kind of blue circle here, that is going to give a specific readmission rate for that MSDRG. So same thing goes with the providers. We have the light gray showing discharges with no readmissions. Dark gray is discharges with readmissions, and then kind of that readmission rate. The one kind of interesting thing about these two is they kind of interact with each other. So if you were curious about looking at a specific MSDRG, let's say I'm interested in which providers saw patients with a specific MSDRG. If you click on one of the dashboard MSDRG names, then the provider readmission rate by provider dashboard chart is going to filter based on what you had selected in the other one. So now this is showing all providers who saw patients with this specific MSDRG. And vice versa, you can do the same thing with providers. Let's say you're interested in one of the providers, you want to see what MSDRG they saw patients for. You can go ahead and click that. The other thing you can do is you can only view categories with readmission. So then you would just select yes on this filter, and now it's going to populate the dashboard to only showing either a provider or MSDRG that had readmissions. So that's just a quick highlight of the rural readmissions dashboard. And the next one I want to share with you is our rural market share dashboard. So same kind of concept as our other one. Like I said, all the dashboards are going to list the dashboard name on the top. It's going to list the time frame. So you can see here, this is a rolling 12 quarters, which is typical of most of our dashboards. You'll select your facility. Again, I kind of already pre-populated this. So you have the peers. You have the option to enter in patient zip code, which then gets applied. And then you have a place of service. You have an option to look at visits or charges. You can choose your quarters and your primary payer. So this first dashboard is looking at giving you a high overview of, for this, all these specific filters, what is my facility's market share? We have that broken down by primary diagnosis category, and then we also have it listed as a market share over time, so a timeline chart. And then this one on the bottom is looking at market share for all facilities. So breaking down the peer facilities that we had looked at, looking who in the dark blue, those are peers that we selected. What is their percent market share for the zip code that we're looking at? My facility that I have selected in light blue, and then any other facility listed in gray just means that they had a percent market share. So the other last thing I want to show you is Cavio quickly, and this is our kind of data visualization platform. So when you come in, you have the option to select a facility you specifically want to look at. You have the option to look at all these places of service, time frame, that sort of thing you can select. And then you can filter by all of these different categories here when you actually get into Cavio. So I, again, made some pre-selections, but once you fill in this kind of landing page with your filters, then you'll come into the dashboard and it'll look a little something like this. So for example, here, I just pulled up primary diagnosis category looking at inpatient place of service. Now I selected all facilities, but what it's going to do based on whatever facility you select is it's going to populate. It populates automatically number of visits and median total charges, but it's going to give you that for each facility because that's what I have selected. You have the ability to change some filters. You can add up to 3 filters at a time to really kind of dive into the data. And there's a lot more within here. You have some option to select some pre-populated graphs and charts here. I won't get into those quite yet today because I want to give the other presenters some time to share theirs. But this is just going to kind of a really, really high level snapshot of what Cavio might look like. And the other thing I'll mention is within all these dashboards, they're all exportable. So the images that you're seeing, you have the option to share those via an image, a PowerPoint, PDF version, whatever it is that you're interested in looking at. But with that, if you have any, I don't know if there's any questions in the chat, but if you do have any, please feel free. I will help try to answer as best I can right now. But if you have any other questions, please don't hesitate to reach out to me. My email here is listed. And like Samantha said, the PowerPoint slides will be sent. So again, please don't hesitate to reach out. I'm happy to answer any questions that you might have. Thank you very much.
Thanks, Emily. Yeah, I will be sharing some resources and everybody's email addresses will be on them. So do feel free to reach out. And if you have a question while we're here, pop it in the Q&A section or in the chat. I'll be monitoring both. But otherwise, it's over to Janet for the co-op's presentation on their quality indicators and Cary Health Safety Zone programs.
Thank you, Samantha. Hello, everyone. Glad to see you. I'll begin sharing my screen. Please give me a shout out if you are not seeing my PowerPoint. or if you are not seeing it well, okay? I'm just going to adjust it a little bit. So I'm Janet Wagner. I'm the Rural Wisconsin Health Cooperative Quality Services Senior Manager. And I'm here to just tell you a little bit about the portfolio we have for selections for the SHIP grant. And for those of you who attended this last year, some of this may look familiar as the Rural Wisconsin Health Cooperative Quality Indicators Program. I'll be featuring as well as the Clarity Healthcare Safety Zone tool. So the RWHC Quality Indicators Program is a software program that we offer for data collection, data analysis, reporting internally, as well as data reporting to CMS and also Joint Commission if you're Joint Commission accredited. The software includes measures that you can select. The required measures for the MBQIP include the outpatient 18, that ED throughput measure, the emergency department transfer communication measure. You can collect that data in our software, and then we submit that directly to Wisconsin Office of Rural Health. We can also submit the hybrid hospital-wide readmission measure, as well as a hospital-wide mortality measure, if you wish, and that safe use of opioids ECQM measure. Our program also allows selection of measures for internal analysis and improvement, even if they aren't required by MBQIP or CMS or Joint Commission. So, what else is included in this program? We do consulting on the requirements and the measures. And this includes, sometimes I'll make cheat sheets, forward you emails, or make sure you're on a listserv. I know a number of hospitals have new people working in quality, so I just try and give a heads up now and then to make sure you've seen something, there's been a change. We have benchmarks for the measures from the small rural hospitals nationally that submit their data and collect their data via the RWHCQI program. All of these hospitals are small rural or critical access hospitals, so it's kind of nice to have a benchmark for kind of like-size hospitals. There are multiple data reports that can assist you in your analysis, and you can run these reports monthly or quarterly and even annually to look at your measure scores and compare them to benchmarks and your previous data submissions. And if you wish, when you are collecting your data in the RWHCQI program, you can enter the physician NPI number, and you can include this in an import file. And then you can also run your reports by the physician. So for that OP18 measure, you could run your median times by a specific physician and then see how they compare to others within your organization. There are also individual patient case reports. For those of you who use RWHC, these are those export reports. And this is a report that will show you for a time frame and measure that you select all of the cases that you collected data within our program and how you answer the questions for the measures. So other than just pass-fail on the measure, this shows you the patient's sex, male or female, race, ethnicity, payer, Medicare or non-Medicare, as well as all the other data points that you enter, including postal code, etc. This can also be really helpful for a pretty convoluted measure like that sepsis measure, which isn't required by MBQIP, but I know some of you do internal data collection and analysis for that measure, and this can be really helpful for that as well. So the data that can be collected, this includes those chart abstracted measures. It includes the ECQMs. These are required, of course, for critical access and PPS hospitals. The web-based measures such as that OP29 colonoscopy, not required for MBQIP, but I've noticed a number of critical access hospitals are collecting this measure to try and have enough measures to get that star rating on that CMS Care Compare site. We can also submit the hybrid measures for that hospital-wide readmission and hospital-wide mortality, core clinical data, and again, that emergency department transfer communication measure. So I just thought I'd share with you, we do customer satisfaction surveys because as just like you, we're always looking to find where we may have opportunities for improvement or what we're doing well. And our last survey in October, 100% of our clients that answered the survey said they would recommend our W8CQI program. 100% say the communication is timely, courteous, professional, and knowledgeable. And some of the comments I just like to share. One commenter said that you go above and beyond for our facility when we have needed it most. So again, especially when you have turnover or new people or there's a change in the measures, we try and help you out any way we can with that. And another comment was, thank you so much for these emails, Janet. I just appreciate the fact that this is extra work on your part to share all of these things, but hope you know is very helpful on the backside. So again, you have the opportunity to let us know what you need or what you aren't understanding, and we'll try and send you some information and resources to help you out with that. So we are currently processing our contracts for calendar year 2026. We'd be happy to answer any questions that you have, or you can contact me anytime at my email address here or phone number. Any questions right now that you might have on the RW8CQI program? Okay, moving along. Our other service that we offer is the Clarity Healthcare Safety Zone tool. This is an occurrence or incident reporting tool. It's currently used by 16 Wisconsin hospitals. This is a shared platform for these 16 hospitals. So where it can be lacking sometimes in you specializing it exactly to your hospital, the benefits are that it's less costly than if you were to purchase this tool on your own. We have quarterly webinars where we share data and can talk about challenges and successes we've had. We can talk about where there are opportunities for improvement or where you would like changes in this tool. And this is really nice because you kind of get feedback from what other organizations are doing or not doing and how they're doing things. And with occurrence reporting, this can be, not always information that's readily available. So we're currently contracting on this tool for 2026. And again, you can contact me for questions. And additional information about this tool includes there are 12 different occurrence forms for different types of issues. There's reports that you can run for your data analysis and review for your occurrences. There's benchmark data that's offered by Clarity as well. Again, as I had mentioned, there are meetings needed to discuss and review requests for changes to the forms. And note, though, that not all changes require a meeting, right? You can submit a change that you'd like. Sometimes we'll just go out to the group of, does anybody object to making this change, especially if they aren't a required data field. Sometimes those are very easy to make a change. And while there are some data fields that are required, of course, there is flexibility in the parts of the form that your organization does not have to use if it doesn't fit your organization's need. There is also the opportunity to administer the AHRQ patient safety survey through Clarity. And you can work with Clarity directly. I know some hospitals will do this annually, some will do it every 2 years, but this service is also available to you. And more services available. Again, that the group meets quarterly. We have a falls reduction group. This is a voluntary group where we get together and we review data, make some analysis, talk about opportunities for improvements, what some of your challenges have been with your falls data, what some of your successes have been. And this year we're reviewing, and this is per the request of those who use this tool, we're going to be looking at swing bed falls and we're going to be looking at acute care falls. And this can be helpful as well. I know sometimes you may be considering using something or changing something in your hospital, and there have been so many times during these calls that another hospitalist says, you know what, we started using this 6 months ago and we really like it. And so that can really be helpful to you, and they can get together and talk more about that change. While this is voluntary, we do request that participants make it known at the beginning of the year that they want to participate in this falls reduction program. It's a patient days it's the falls per 1,000 patient days. And the patient days isn't collected through this tool, so you would just email me those patient days directly. And then I provide that blinded data. You have a code for your facility that only you know. And we review the data and who's doing well and who, sometimes somebody who, it's hard to maintain success with, decreased falls. So sometimes if somebody is having a problem, they'll just ask, what are you doing, or what have you done when you've seen this happen? And again, that can just be really helpful to have those conversations. And again, this offers you some benchmark data within the group, as well as we use a AHRQ benchmark for falls. So just a view of some of the forms. I had noted that there are a number of forms you can use. There's a patient or other. And again, this data tool doesn't only capture occurrences or incidences. You can also submit those near misses as well, which, for patient safety, that's where you can really look at if you're trending up in an area of near misses and try and look at what might be causing those near misses and make a change before you actually have a patient safety event. There's an employee form, compliance issues. And these are non-HIPAA related. A utilization review form, decision support or CMS mismeasure form, antibiotic stewardship report, an IS incident form, peer review. Some people track their peer reviews through this. And again, that AHRQ patient safety survey. Any questions at all about the Clarity Healthcare Safety Zone tool? Okay. Well, one thing I do want you to be aware of is that depending on what the fee for the SHIP grant is this round, depending on what your measure selections are for that RWHCQI program, because and Samantha, correct me if I'm wrong, I think they would need to use the full fund amount if they would select our package. So many of you may have already submitted your contract for that RWHCQI program. You have already seen the contract for the Clarity Healthcare Safety Zone. Excuse me, I'm going to cough. So, I've been kind of thinking of last year's fee amount for the SHIP grant as kind of a benchmark for you to consider this year. Any questions?
Just to elaborate on that, this service is usually billed by the co-op on a calendar year basis. So as we award the SHIP grant, that will then be reimbursed to you by the co-op for the amount of the SHIP award. So if you select this this option, your co-op fees will be reimbursed to up to the amount of the award.
Thank you, Samantha.
Sure.
My apologies. Just getting over a cold here.
Sorry to hear that. All right. Well, then over to Sarah. Thank you so much, Janet. It is Sarah's turn to share about the Target Quality Improvement Technical Assistance Program.
There we go. Hi, everyone. Thanks so much for having me today. I am here to talk to you a little bit about some of the offerings that we have from Stratis Health. So I'll start by, if you're not familiar with us, Stratis Health is an independent nonprofit that's located just to the west of you all. We're based out of Minnesota, but we do our work both state-based, regionally, and nationally. And we have a long history of working with rural providers, including small rural PPS and critical access hospitals, around topics related to quality reporting, improvement, patient safety, reducing differences in outcomes, things of that nature. So excited to be here with you all today to share what we are offering on your menu for this coming SHIP year. So our offerings are going to include two different topics. One will be around embedding a culture of quality in your organization, and the other is around improving primary care efficiencies. So before I get into some greater detail about what those two different offerings include, I want to talk a little bit about what our approach is, which is standard across both of those topics. So we would be looking for your team, and I apologize, it says hospital team, but the primary care efficiencies is obviously primary care team. We recommend that you have at least 2 to 5 people on your team, and you would receive one-to-one education, coaching, and resources on the topic of your choice. So we would work with you all to identify your strengths and areas of opportunity in your selected improvement area, provide some directed education on that area to help support action plan development, work with you all on prioritizing your needs, developing your goals, and designing your action plan, and then actually work with you through the implementation phase of that action plan. So receive one-to-one coaching, ongoing education and support and resources as you're working through that implementation process, and then work with you to assess your progress against your stated goals from the initiation phase, and also developing some sustainability planning going forward. So as we work through things and you identify other opportunities that come up, how can we work with you to best set you up for success even beyond that engagement period? So with regards to the topics, the first is embedding a culture of quality. So this is really looking at helping your team develop and embed strong change management skills and using improvement methods for building that solid foundation for ongoing quality improvement across your organization. This can be very broad and general, or it could be in a specific area of interest, such as around patient experience, patient safety, community engagement. So this is about how you do your work, how your team does its work, and how you can make quality improvement not a thing that someone else does in another office in a corner of the facility, but the way that everybody approaches and does their work. So we would really be gearing this towards staff who are responsible for leading quality improvement efforts within your organization, whether that's due to their role or their responsibility, and again, encouraging a team-based approach. Some examples of things that we've done with other facilities beyond, thinking about the patient experience, patient safety, community engagement would be, for example, if it feels a bit disjointed in terms of how staff in your facility understand quality improvement. We hear quite a bit from facilities that folks tend to think sometimes of quality as maybe being somewhat punitive. So thinking about how we can get folks on board to recognize that when we identify an opportunity for improvement, that's not because we did something wrong, it's because we are learning and we're in constant learning mode. So being able to identify those opportunities, knowing where to take those opportunities to, how to kind of report them, whether it's through an incident reporting system or some other type of mechanism that you have for identifying those, and then how to go about actually implementing and leading an improvement process. The other topic that we're offering is around improving primary care efficiencies. So this is really about a structured approach for improving your care efficiencies in primary care, streamlining workflows, improving care team satisfaction through the application of continuing quality improvement practices. So we're looking at rural clinical managers and providers and other staff in those clinics to best be able to identify opportunities and lead implementation of workflow efficiencies across various roles. Some examples of things that we've done in this space with facilities is, for example, lab results not being available during the appointment, RX refill process for patients with chronic conditions that aren't synced regularly, the amount of time providers are spending in the EHR outside of clinic hours, and their EHR inbox volume being unmanageable. How can we help everyone within the clinic work to the top of their capacity and capability to find efficiencies, to be able to save time for the staff themselves, to be able to save time for patients, and to hopefully be able to improve team satisfaction overall. Other topics are patients not showing up on time for registration or check-in, patient waiting time for registration to rooming, lack of standing orders, staff not having really a heads up to the day's nuances. So some relatively straightforward or seemingly kind of obvious issues that a lot of clinics are facing. How can we work with you all? And we use AMA's Steps Forward as a standing resource to be able to support those improvement processes. But the Steps Forward resources are fantastic. They are not developed specifically with rural facilities in mind. And so we're able to take those resources and kind of tailor them and tweak them to be able to support you in your rural facilities and your rural clinics with your workflow improvements and for efficiency. So it's really a very brief overview of what it is that we're offering to you all, but welcome any questions or comments that you might have, and happy to explore this opportunity with you further as you're making your decision about how you'd like to use your SHIP funds this year.
Cool. Thank you, Sarah. I don't see any questions in the Q&A or in the chat. So I will move on. Just going to reiterate a couple of things for anyone who missed the first couple of slides. Our SHIP for the year is our SHIP for this current fiscal year, 25-26. We've got a couple of ongoing things. Please get your contract signed and submit your invoices. Our SHIP 26-27, we will be sending out a package that'll include all of the information shared today, and all of the links. And please go through that, fill out your midpoint reports for the last fiscal year and applications for the upcoming fiscal year in Qualtrics, and make sure that we have the right contact details for you. If you have any questions, feel free to email me and I can route you to the correct person that will have the answers for you, or email the people directly that have spoken today if you have questions about their projects. Okay, I don't see any questions. Still don't see any questions. Megan, am I missing anything that I should have told people?
I don't think so. All I would add is to make sure you're signed up for our newsletter, the Rural Health Radar, to stay up to date on any new information.
That is a great point. Yes, please do sign up for the Rural Health Radar, and you can do that by going to our website, war.org. That's WORH.org, and you'll see a sign up link on the front page. Okay, and since there are no questions, I will end the webinar now. Thank you all so much for taking time out of your day to be here. Thanks to all of our presenters, and I look forward to getting all of your application forms by January 23rd. Have a great rest of your day. Bye.
Thank you.
Thank you. Bye.
Bye.
Okay. Are you seeing my screen?
Yes.
Yeah.
Are you seeing the right screen? There. Okay. Hi, Sarah. Welcome. Okay, we are at 2 o'clock. So